So now we have passed that tube, the inference would be that we are all good and we can sit back and relax. But of course that is definitely not the case and we have still got work to do. The first and most important task we have is to ensure that that tube is in the right place. Unfortunately, in the very recent past, reports in the media about the failure to recognise esophageal intubation, and these cases are absolutely tragic. But when I think of these and I read these reports, what I always try and remember is that none of the clinicians in these cases set out to cause harm. And because of that, there is clearly the potential for error here. And that error might have absolutely catastrophic consequences. Now we're all fallible, so we all need to know about this. So let's think about tube confirmation. In the Safer Pre-Hospital Anaesthesia Guidelines, they talk about tube confirmation using a standard clinical assessment and using waveform capnography. So what does all that actually mean? Well, we have the absolute gold standard for confirming intubation, and that is waveform capnography. Specifically, more than 7 beats of capnography via our end-tidal CO2 monitor. Now, if that isn't there, the absence of a recognisable waveform indicates failed intubation, unless proven otherwise. That's a key bit, and so often this is the element that has been misinterpreted in these cases. Put simply, no trace, it is a failed tube. And this is true even in cardiac arrest. The waveform might be a bit smaller, but crucially it will still be present to some degree. So sorry to hammer this home, but for intubation, alive or in cardiac arrest, you need to be seeing some reliable end-tidal CO2 trace. So they also talk about that standard clinical assessment. Well, this is everything else that you might see out there in practice. So the operator seeing the tube go through the cords is normally a good sign. Potentially the whole team might have seen that if you're using a video laryngoscope. Misting of the tube is also a good sign. Hearing air entry on auscultation of the lungs is an okay sign, but it's definitely not perfect. Symmetrical rise and fall of the chest is again another okay sign, but not perfect. Having a good peripheral oxygen saturation is an okay sign, but potentially there could be a really big lag in recognising misplacement as it takes time for that hypoxia to occur. So lots of elements in a standard clinical assessment, and I still do all of these. But the most important step in confirming correct placement of that tube is reliable and consistent waveform capnography readings. Without it, you are not in the right place. Okay, so now we are happy with the placement of our tube. The next thing is securing it. There are several different potential methods we could use here. So a tube tie. This is really common. Most people are happy to use them, and normally it enables you to get a good bite on that tube before then feeding the tie around the back of the patient's neck and tying it on the side of the face somewhere. You might have a specifically designed device, so say something like the Thomas tube holder, if those are available in your service, fantastic. Or potentially, you could tape that tube in, which is often used preferentially in very small children and neonates. Now, the AAGBI document doesn't specifically state what to use, and I haven't seen any studies directly looking at which is the best approach when considering oral intubation. But that document does state that it might be appropriate not to tie the tube around the neck in cases of head injury, as this may impede venous drainage, and the knock-on effect of that is it could increase the intracranial pressure. So in those suspected head injury patients, it's probably better to use tape, or you could tie that tube tie above the patient's ears rather than around the neck. The next step after that tube is secure is to provide some oxygen and ventilation, and in most cases this will be initially done by using either a self-inflating bag or a Mapleson circuit. I think it's really important to do that in the first few minutes, to use that manual approach, as you're getting some really crucial real-time information, tactile information about that ventilatory pressure. And that's key, as you can get a lot of information from that. So when you encounter those very high or very low ventilatory pressures, you want to be checking for a problem. And there's a really useful mnemonic out there. So the DOPE mnemonic. So the D, well, that stands for displacement or dislodgement of the tube. O, that stands for obstruction. So thinking about mucus plugs, about blood in the tube, about other secretions that might need suctioning, or the kinking of any tubing. P, well, that stands for pneumothorax. So is there any clinical evidence of a pneumothorax? So reducing oxygen saturations, unilateral chest movements, etc., etc. E, well, that stands for equipment malfunctions. So check your tubes, your cords, look for blocked filters, all of those. So once you are attached, if there is high or low ventilatory pressures when you're squeezing that bag or that Mapleson circuit, think about the dope mnemonic to troubleshoot. The awesome thing about this is it also applies to troubleshooting the ventilator. So getting your patient onto a ventilator is something you want to be doing as soon as reasonably possible, as it will free up a team member and provide you with more accurate control over the strategy you're going to use. Just simply much less variance in what you're providing to your patient. Now, we've done a whole podcast on this specific element of care, nearly an hour long, so this is going to be very much an overview in the next few minutes. But if you want to know more, it's all here in this episode, an hour for you specifically on this. So the first question is, what goals are we going to be looking to achieve by using a ventilator? Well, ideally, we want a patient who is well oxygenated, and that's using that Goldilocks analogy. We want to avoid hypoxia, but we also want to avoid hyperoxia. So peripheral oxygen saturations at the patient's normal level, or if we don't know what that normal level is, somewhere between 94 and 98%. We want a patient who is well ventilated, and this means we want a reasonable respiratory rate, so somewhere between 10 and 15 breaths per minute as a general rule. We'll talk about specifics in a minute. But we also want a reasonable end-tidal CO2. So for our post-cardiac arrest patients, for example, the Resus Council tells us to aim for a partial pressure of carbon dioxide between 4.5 to 6 kilopascals. But this is done via blood gas. And this is different from the end-tidal CO2 reading you will have, as end-tidal CO2 also reflects any alveolar dead space. So now in terms of correlation, a general rule of thumb is that end-tidal CO2 is normally about 0.7 to 1 kilopascals lower than your partial pressure of carbon dioxide. So that's where you want to be targeting it. The final wish here is that we don't go using too much pressure to deliver these breaths. And this can potentially result in barotrauma to the lungs, along with increasing the cardiovascular instability and problems that are caused by invasive positive pressure ventilation. So with those goals in mind, let's look at our initial setup of that ventilator. Specifically, the mode, the rate, the tidal volume, the PEEP, the FiO2, and the pressure alarms. Right. What ventilator mode do we want to use then? Well, on ITU, there are lots of different strategies that can be used, but for our patients, well, they've just received an RSI, so they will not be making any respiratory effort at all, and this means the ventilator will be doing it all. Something you will hear called CMV, or controlled mechanical ventilation. Now, there are two different ways of controlling that, one volume controlled and one is pressure controlled. And in very simplistic terms, that means during volume controlled, the ventilator will deliver a set tidal volume using whatever pressure is needed to reach that setting, although you can also add a pressure limit on most modern machines. During pressure controlled ventilation, the ventilator delivers a flow to maintain a set pressure at a set respiratory rate over a set inspiratory time, which also needs to be set. So once you've decided on your mode, the next thing is to think about the rate. And this is going to be set in that ventilator somewhere between those 10 to 15 breaths that we talked about earlier. Although in some cases that might be a bit higher. Say, for example, if the patient has got a metabolic acidosis and they need to compensate by getting rid of more CO2. Next up is the tidal volume. And all of the guidelines that you see out there currently will recommend giving 6 to 8 mils per kilogram tidal volume. So for your patient who is 60 kilograms, that's going to be 360 to 480 mils tidal volume. For your patient who's 70 kilograms, it'll be 420 to 560 mils. And for your patient who's 80 kilograms, it'll be 480 to 640, etc., etc. A very useful thing to keep on a cheat sheet on your phone or in your pocket on your leg. PEEP, or the positive end expiratory pressure, can be really useful to improve ventilation perfusion mismatches by splinting open airways that might otherwise be collapsed, which will decrease the atelectasis, therefore improving alveolar ventilation. Initially, in most cases, it's going to be set to around 5 centimetres of water initially, but it can be increased anything up to 20, but initial settings around 5 is fine. Now the FiO2, or the fraction of inspired oxygen, well, this setting will depend on a couple of factors. Firstly, the ventilator you have might determine what you can give, so some older models have 100%, 50% or nothing. Others allow you to set the exact amount depending on your patient needs. And that exact amount will be determined by their injuries or illness and their comorbidities, but will generally be somewhere between 94 to 98% on your peripheral oxygen saturations. Now, your pressure alarm is probably the final thing to think about, and it's generally accepted that a peak inspiratory pressure of less than 35 centimetres of water is the upper limit of acceptable. So typically it is good practice to set alarms to trigger around 30 centimetres of water, as that allows you to go looking for the cause of that high pressure alarm. Again, thinking back to that dope mnemonic in terms of what we're going to check. So in summary, the gold standard for confirming intubation is waveform capnography. No trace, then that tube is in the wrong place. In addition, of course, though, you can use those other standard assessments, but that is the gold standard. Once you've confirmed that tube, you need to secure it using whatever methods you have available to you and taking into consideration the exact nature of that case you have. If you've got high or low pressures when you initially ventilate that patient with a self-inflating bag or a Mapleson circuit, then think about that dope mnemonic. Try and find out where that problem might be and correct it. Finally, think of the goals you're trying to achieve when you set up that ventilator. And of course, check out that full podcast if you want to know a bit more on it.
Lovely. Another nice little section there, Rob. And actually, you challenged me there. I was really struggling to think of a good question, but you'll be pleased to know I've got one.
Very kind. Very kind.
Maybe slightly searching question, this one. Any thoughts on using a mechanical ventilator during CPR and chest compressions?
So fair enough. That is a good question now, and
good.
Yeah, as I struggle squirming in my chair. Now in practice, to be honest, I do prefer to manually support ventilation in the early stages of arrest, much as I just discussed a few minutes ago. Once that tube initially goes down, and that's really to provide that same sort of level of tactile feedback, but also that we don't have to all listen to the pressure alarms going off the whole way through in the first few minutes, which are quite stressful enough. However, there is some good evidence around the utilization of ventilators, and it does suggest they certainly can be used even with chest compressions ongoing. So potentially this is definitely something you could try, or specifically, I guess, really in those prolonged arrests would be where I'd consider it most. So for example, those cases, where you're trying to correct a hypothermic cardiac arrest, or a patient who's taken an overdose and we know this is going to be a long resuscitation effort, or in those patients who are being thrombolized for, say, a massive PE, etc. And, it comes into its own really when you couple it with mechanical ventilation, I think. So, yeah, initially, I personally don't. However, there are some circumstances where I would consider it. I mean, what's your thoughts on it? You do a lot of these, don't you?
Well, so, you'll be pleased to know that I think my thoughts echo yours very closely, Rob.
Always nervous throwing it back at you.
Close. But no, you're right. I don't think I can think of a situation where I would immediately put a cardiac arrest patient onto a ventilator. But I've certainly used it in the situations you've described, particularly hypothermic patients who we've got on the Lucas and we're transporting into hospital. Definitely have used it then. I think the other time that I've used it, and this isn't regularly, and I think we don't know for sure how efficacious this is. And I think if you're going to do this, you need to do it very cautiously and with a lot of thought and a lot of attention to the monitoring of the ventilator parameters. But the situation that I have done this in is when you've got a post-ROSC patient and they've got a really well-seated advanced airway, probably a tube, although I guess I would consider it with an iGel, but I'd be slightly more cautious. And those post-ROSC patients who then go on to have a subsequent rearrest. And I might not automatically take them off the ventilator. But what I would do is be guided by some of that research that you've talked about, and I'd tweak my ventilator settings. So thinking about the mode, I would put them on SIMV. I would have the rate down to 10, and I would adjust the I to E ratio to 1 to 5, so you're delivering your inflations over 1 second. The tidal volume is going to be set somewhere around 6 mils per kilo. I take the PEEP off completely and set the FiO2 back up to 1 if you've been titrating it down. And finally, you mentioned those pressure alarms, Rob. I would turn those right up to maximum so that you're not getting the alarm, but you're also not getting a blow off so that you are delivering the volumes that you think you are.